The post-op period begins after the last incision is stapled or sutured, and the patient enters the post-anesthesia recovery unit or PACU.
What's that, 478?
438. Okay, so these are standard questions that you'll ask if not provided in the SBAR report. So when you're the receiving nurse, these are the information that you would want to have on hand before you receive the patient. If any of them were not volunteered by the reporting nurse, the PACU nurse, then you ask for it. Are we clear? All right. So these are the basic things you need. What was done to the patient? What was the diagnosis? Okay, how much blood loss was the patient has the patient sustained? What was the time of the last pain medication administered? Are there any drains? Okay, what fluids are hanging? All the way to vital signs, and if there are any events that happen, or let's say special requests. Some patients families stay on the post-op unit. Sometimes they follow them to the OR waiting room. So if the patients or the families have any special request, then follow them. Okay, so let's say they wanted to be called after the patient is sent to the post-op unit. Okay, or let's say if there's any complications from the surgery, let's say patient fell off the OR table, you would want to know that, correct? Okay. So here comes your duties now. So you receive the patient after receiving all this information. So the reason for getting this information is you want to see whether or not the patient is stable enough for you to receive them. Is that clear? Because if you just receive them without any report, especially the latest vital signs, then if the patient doesn't sound stable, should you be in any business receiving this patient?
No.
No, it's not like you're not capable. It's because the patient is not safe with you. Because if you're on a post-op floor, this is not your only patient. Patient requires higher care, then they don't belong in your post-op unit. They belong somewhere in ICU. Is that clear? Right. So what do you assess upon receiving the patient? Okay, first, of course, is your vital signs, and then you look at the dressing, look at the incision, see if there are any stains on the dressing. Is it saturated? Okay. In the case wherein it is stained by drainage, describe the stain. Is it red? Okay. How red is it? Is it like, does it look new, like a fresh bloody drainage, or is it like a dry drainage, indicating that it's been in the PACU for a while? Okay, because they stay in the PACU a minimum of 1 hour all the way to 6 hours. So you can tell whether the drainage on the dressing is fresh versus if it's old. It's already dry, so that means it's been there for a while. Either way, you outline the drainage with a pencil. Okay, you use a pencil to outline the drainage. That way you can trace, you can observe the drainage, whether it's increasing or not. Because the first dressing change usually is done by the surgeon, the surgical team, unless they give you permission to change the dressing yourself. All right, again, if it's the first dressing change, that's usually done by the surgical team. There are surgical residents that will come make rounds and change all their post-op dressings, unless, again, otherwise instructed. Are we clear? All right. So the routine for vital signs is every 5 or 15 minutes for the first hour, and then it decreases with frequency on the next hour. You go every 30 minutes, then every hour for another 2 hours, etc. Then routine after that. Check the airway, especially if the patient had, most of your patients that had surgery are either on moderate, managed anesthesia care, meaning MAC. The MAC means they were just moderately sedated, meaning they were not intubated at all. So for major surgeries, they are, of course, they were intubated and put on a ventilator, depending on the site of the surgery and also the length of time of the surgery. Same thing for Foleys. They may or may not have Foleys anymore, depending again if they're voided or not yet. So prioritize airway first, especially if the patient had an artificial airway, meaning they received general anesthesia. Okay, so assess the airway. Are they swallowing okay? Can they follow commands? Who are planning to become CRNAs here? Okay, very nice. Next is your cardiovascular status. As far as vital signs, any vital signs that are 25 millimeters of mercury higher or lower from your baseline is reportable. Okay, that's a significant change. Same thing for the heart rate. The heart rate is 20 higher, 20 beats higher or lower. The guideline is either 10% change or 25 points change. Does that make sense? Okay. Bleeding is common in any surgical patient, so assess for signs of bleeding. It may not have been apparent at the PACU, okay, obviously because they were discharged from the PACU, but bleeding can occur at any time after the surgery, so monitor for obvious as well as hidden signs of bleeding. So how would I know if it's hidden? If it's obvious, of course, you'll see the blood coming out, but if it's hidden signs, what would be your indicators? Okay, blood pressure and heart rate will. Okay, all right. Okay, so I already mentioned this earlier. So that's your reportable changes in vital signs. Then check for shock. We already finished for shock 2 weeks ago. Hemorrhage, this will be mentioned again next week when we do peptic ulcer disease. So we'll skip that for now. Hypertension and arrhythmias. Now, patients will react differently to the anesthetic agents used, maybe opioids, depending if they are opioid naive or opioid tolerant, and the anesthesia also. So check for any abnormal heart rhythms. Pain management is expected. So unlike this morning, there were three groups that did not perform a complete pain assessment on Mr. Carl Shapiro. Okay, so perform a complete pain assessment on your post-op patients. Post-operative nausea vomiting is common. So in addition to pain, why is there nausea vomiting after surgery? Is there peristalsis? Okay, so there'll be little to no peristalsis. Plus, this could also be side effects from anesthesia and the opioids. Again, especially if the patient is opioid naive. We control nausea at the first indication. We do not wait until it's full-blown. We have medications that are, actually we have a list here. Okay. So most post-op patients will have multiple antiemetics ordered. They work differently. Now, key here is you have to know which one to give for what type of nausea. Now, there are three types of nausea. We've got acute, meaning I'm nauseous now. We also have anticipatory nausea, meaning let's say it's a chemo patient that they haven't even received the chemo yet, but the thought of having chemo already makes them nauseous. So we call that anticipatory nausea. And then there's delayed nausea vomiting, meaning even if the patient had chemo last week, they're still nauseous now. So same applies for surgical patients. Even if the surgery was already 3-4 days ago, some patients may still be nauseous. So how would you know which one to give? Now, as you can see, there are different ways these things work. For instance, a GI stimulant, which is metoclopramide, this relieves nausea by increasing peristalsis. So what is a natural consequence of this? If it increases or promotes peristalsis, it could be diarrhea, but I like metoclopramide for post-op patients because this decreases or it facilitates peristalsis, especially if my patient has an abdominal surgery. So rather than dealing with prolonged nausea because there is, ileus, for instance, so this drug will promote peristalsis. So I like metoclopramide. Phenothiazine or prochlorperazine, this is available in all forms, especially rectal. So prochlorperazine, I like because if you're nauseous, can you give anything by mouth? No, so I like the suppository form of this. Promethazine was off the market for a while because it was associated with IV complications, but I guess they've been reassessed and they're back on the market now. So Phenergan or promethazine is back now and it's still available for IV or IM injection. The benefit, it can also be used for cough. Promethazine, the benefit here is it's sedating. So therefore, are you nauseous if you're sedated? No. So a side effect of promethazine is sedation. So it's good, right? I mean, if you're nauseous, you would want to rest, right? So that's good thing about this drug. Diphenhydramine, this is this is not Benadryl. This is dimenhydrinate. So this one is a antiemetic but used primarily for motion sickness. Okay. And so on, hydroxyzine, scopolamine, ondansetron, which is Zofran. Now, how do you know which one to use? Look at the nursing implications. How does it work? So if this is the action of the metoclopramide, is it good for anticipatory, acute, or delayed nausea?
Acute.
This is good for acute. What about this one? Prochlorperazine or compazine? The second. Control of severe nausea.
So like the chemo one.
Acute. Very good. What about this one? Promethazine. Acute also acute. Okay. What about this one?
Prevention for
Okay, so do you give this when they have nausea or before they even complain of nausea? Okay, so this one as well as ondansetron, both good for prevention. Okay.
They even use scopolamine too.
Yes, scopolamine is better in its patch form rather than the transdermal. This is the more effective use of scopolamine. They put that behind the ear and controls nausea.
You know what they use that for also? Called the double stroke.
Or
They like blow it on you.
Yeah.
At high doses.
okay.
Basically, it makes
Right. So what's the big deal about controlling nausea? What does nausea hinder when your
It's the-
patient has nausea after surgery?
Oh, the tears.
It could hinder healing, right? Especially if you have a abdominal incision, it could even cause dehiscence or even worse, evisceration, right? So it's very important. Plus, what will this also prevent the patient from doing? If you're nauseous, do you want to eat?
Yeah. Oh yeah.
Yeah, nutrition will be impaired here. So you'll have to deal with electrolyte imbalances now, especially hypokalemia, because the patient's not eating, they're nauseous, they're miserable. Right. So it's really important to control post-op nausea and vomiting. I won't test for PACU discharge. In the first place, we're not expected to work in the PACU, we can skip that. This involves Aldrich scoring. So they follow this checklist, and if the patient passes, meaning there's now a return of, meaning they're basically stable, then they can be discharged from the PACU. Post-op patients can be ambulatory, or meaning same day surgery, meaning after the surgery they go home. Examples are cataract surgeries, or let's say endoscopies, or let's say appendectomy. Appendectomy are, well, most of them are still inpatient, but the younger the patient, they can actually go home the same day. Okay, because we do most appendectomies now laparoscopically. So the patient may stay in the PACU for, I don't know, 4 hours, and then they go home. Okay. They follow up outpatient. Unless there's complications, then they stay overnight. And this is your discharge teaching for the patient. Important is the care of the incision, use of the drugs, the pain management drugs, or if there are any antibiotics prescribed, and then more importantly is the follow-up. Now, if the patient goes home with a staple or sutures, please make sure they're aware of when to come back. All right? Staples usually are removed 7 to 10 days after the surgery. If they forget, it goes beyond the 10 days. Not just infection. The staples disappear. By disappear, meaning it's not visible anymore. Skin will grow over the staples. Now you've got a foreign object underneath skin. So that requires surgery again. So now you have to take the patient to the OR, cut the skin, and remove the staples. Are we clear? Right. We've done that before. It has happened before. Wherein, I mean, nobody followed up. The patient was forgotten, basically. Okay. So the only way I saw was there was something shiny that caught my eye. And I saw, oh, that looked like a staple. Then, oh, what did you have? And then when I felt under the skin, there's a whole line of staples that are no longer visible. Okay. You won't see it unless you feel under the skin. And you say, oh, there's staples here, right? So that's a major issue. Okay. So somebody probably lost their job because of that. Right. Okay. To prevent complications after surgery, these are the complications. We got pneumonia, or at least lung collapse or atelectasis, DVTs, hemorrhage or bleeding, infection, and wound dehiscence or evisceration. Let's take a look at each one briefly. Start with pneumonia. Pneumonia can be prevented by the use of the incentive spirometer. So let's review. How do we use an incentive spirometer? Mr. Derek, how do we use it, sir? Let's say this is the mouthpiece. Pick up your pen if you have a pen. Or your strings, your hoodie drawstrings. Okay, so let's say that's the mouthpiece. What do you do? Show me. Do we inhale fast or slow? Okay. Take a slow. You yawn into the mouthpiece. Okay, so you exhale fully first, and then put it in your mouth. Seal it with your lips, and then you go. Okay, really slow and deep. Okay, and then after that, you exhale. Next question, how often do we use it? How often, Derek? How often does the patient use it? Anyone wanna assist Derek? Miss Cornett, how often do we use incentive spirometer? Miss Rivera. Fine, 5th semester. This is fundamentals. 10 times, yes, sir. Go ahead, say it again.
10 times at least for 2 hours.
10 times every waking hour. There's no limit, okay? 10 times every waking hour. So that means if it's 10 times an hour, do they do it consecutively? No, 10 times only, which means once every
6 minutes.
once every 6 minutes. Are we clear? Do they do it like this? And then,
It could be.
no, they have to rest between inhalations, okay? So once every 6 minutes. So that will prevent two things. That will prevent lung collapse and pneumonia as well. Other preventions for pneumonia include pulmonary hygiene or pulmonary toilet, which is turning, coughing, deep breathing. When they have an abdominal incision, teach them to splint the incision before coughing. Put a pillow over, hug a pillow over the incision. Or on page 447. All right. Bronchodilators will also help here, especially if the patient has history of chronic lung disease, COPD, asthma. Now, a contraindication for coughing are those that have undergone any cranial surgery. Okay, they actually have a no cough order or a do not cough order. Same thing, yeah. Eye and brain surgeries. Take note, brain surgeries include transsphenoidal, because some surgical approaches for brain surgery is through the nose. Okay, so that's not any different. Early ambulation will prevent pneumonia. Okay, so in addition to this is better. Early ambulation is better than incentive spirometer, turning, coughing, deep breathing. Ambulation is the best. Now, how will they ambulate if they're in pain? Okay, so another responsibility is to manage the pain. So for those scheduled for physical therapy ambulation, make sure you coordinate with the PT and pre-medicate the patient 30 minutes before the schedule. They'll call you anyway, so they'll coordinate with you. Hey, what time can I walk the patient? Then make sure you pre-medicate the patient before that schedule. And another thing is pain management encourages ambulation, of course, and ambulation in turn prevents pneumonia and also DVTs. Okay. PCA, we already discussed this last semester under pain. Won't repeat that. Why is this so big? Okay, drains. So under wound care, surgical drains are left in gallbladder surgeries, exploratory laparotomy surgeries, meaning extensive, midline incision surgeries. Spine surgeries also have a drain. Mastectomies have a drain. Hip and knee surgeries have a drain. Your responsibility with the drain is, let's say it's depends really on what type of drain was used. I'll show you the picture later. Hydration is important. Another reason for or risk factor for DVTs is dehydration, because these patients have been NPO. So in addition to potassium imbalances, which is usually hypokalemia, In addition to that, the patient may also have constipation or low blood pressure. In either case, if the patients have less blood volume, meaning adequate red blood cells, but then less blood volume, that means circulation is
Decrease.
decreased, meaning it's very viscous. So that promotes DVTs. So make sure they're well hydrated. Again, early ambulation will prevent most of these. The only thing early ambulation, actually, it will still prevent infection because if they're ambulatory, then it will actually mobilize the drainage. Okay, so yes, early ambulation will cure or prevent everything. Okay. If they cannot ambulate, then at least do leg exercises in bed. And if the patient's risk factor for DVT is really high, then consider pharmacologic interventions. Okay. So prophylactic doses of anticoagulants include heparin 5,000 units or Lovenox, which is enoxaparin, 30 or 40 milligrams, depending on the patient's weight. And you know the sequential compression devices, right?
Mhm.
Okay, so question. When should they be on? When the patient is in bed or when the patient is out of bed?
In the-
Okay. What about if they're in the chair or recliner? They're not in bed.
What is phases? What is
Okay. Whenever the patient is not ambulating, those sequential compression devices must be on. Are we clear?
Mhm.
All right, let's go to wound complications. Most surgical wounds are wounds that heal by first intention. First intention meaning the patient did not lose any tissue at all, meaning the doctor just made one clean incision. The patient did not lose any tissue. So does it take long to heal? No, because once you stitch or staple the skin, that's it. It will reapproximate, heals in a few days. Second intention wound healing. These are now wounds like a pressure ulcer, for instance, wherein the patient lost significant, moderate to significant amount of tissue. So that has to heal in two phases. There has to be granulation tissue growth first before the skin can close. Understood? Okay, so that's the difference between first and second. Now, a tertiary intention wound is an infected wound, meaning it takes 3 steps in order to heal. First, the infection has to resolve first. After infection resolves, then granulation tissue can grow, and then the skin can close. Understood? Okay. I won't test this chart. Let's go next to the factors that will affect wound healing. So here they are. Table 16-3, patient's age, older patients, of course, hygiene. Okay. Now, bathing protocol for post-op patients, we have chlorhexidine soap. This is 4% chlorhexidine. It comes in a liquid soap. You're familiar with the dressings, yeah?
Mhm.
I mean, cleaning, the sticks, okay? But it comes in soap. So we start using chlorhexidine soap pre-op and then we continue post-op.
What about Hibiclens?
Say again?
Hibiclens?
Hibiclens is the brand name for chlorhexidine. Hypovolemia or dehydration that affects healing. And then if the patient has diabetes, or let's say these factors here, there's too much swelling or edema in the site, or let's say the dressings are too tight, or the patient is malnourished. These will all delay wound healing. Or if the patient is taking steroids, for instance, or let's say taking other immunosuppressants like steroids. Anticoagulants, your patients who have AFib or let's say history of PE or history of DVT will be on anticoagulants, and that will promote or increase the risk of bleeding. Antibiotics, if not used appropriately. Now, for surgery, the patient will, under the Joint Commission core measures, there's prophylactic antibiotics. If it's a prophylactic antibiotic for the surgical patient, it is stopped 24 hours after the incision is closed. Okay, I repeat, the prophylactic antibiotic dosing stops 24 hours after the incision is closed, meaning the end of surgery. So if I have surgery today and it ended at 3:45 p.m., when will my last dose of antibiotic be?
Tomorrow.
Tomorrow at 3:45 p.m. It may not exactly be at 3:45 p.m. because we don't know the frequency, right? But the first dose of antibiotic is given when? 1 hour before the first incision. Okay, so the order will say, it will appear there. So let's say it's ampicillin. Okay, ampicillin 1 gram, on call to surgery, meaning on call to OR. You as the nurse have to coordinate with the OR. Who's picking up the patient when, and who's gonna give the prophylactic antibiotic? Are we clear?
Mhm.
Because we don't know their schedule downstairs. Let's say the patient is scheduled at 7 o'clock, but that's not necessarily the first incision, meaning the patient will be taken down to the holding area. They still have to do their powwow, their timeout, and then assess the patient. And then we don't know what will change. So therefore, unless you're told specifically to give the antibiotic, do not give it. Okay, because if it's given too far from this first incision, then that's, that could affect infection. Okay. Because it's really important to be given 1 hour before the first incision. And here are your other factors that will affect wound care healing. We already mentioned about vomiting earlier, and the immunocompromised state, and of course, the patient's nutrition. All right, let's go to the drains. So we've got a few drains here. We've got the Penrose. Penrose is drainage by gravity. So it's basically just a flat latex tube that they put in place. It can slip, so therefore it's usually kept in place with a safety pin. Okay, so the safety pin will prevent the tube from slipping into the wound, okay, slipping into the incision. So it's held in place by a safety pin. This is called a JP. JP is a passive suction type of drainage, meaning for this to work, you have to compress the bulb before closing it. That way it will apply passive suction on the incision. Hemovac drain, same thing, same as a JP or Jackson Pratt. This is also passive suction. For this to work, you compress there will be springs here, and you compress the springs and then close the cap. That way, same as a JP, it will apply passive suction. Otherwise, they're just draining by gravity, which is not effective. Okay, so they have to be compressed, okay, for them to work properly.
Similar to the wound vac. Similar to the wound vac.
No. Wound vac is negative pressure. That's different. Yep. Okay, so since you asked about wound vac, it's a long. Let me just describe it this way. So this is a wound vac therapy. This is used for extensive wounds, tertiary intention or secondary intention wounds. What you're looking at is a large wound. This black thing is called a sponge. It's a clean sponge. This disc, so they apply the sponge and then cover it. You can't see it because there's an invisible tegaderm here. They secure it with a clear dressing, And then once you cut a hole and then apply this disc is connected to a suction machine. But it's not a regular suction machine because the pressure is specific. You know, it's 125 centimeters of water or millimeters of mercury. So the machine is not your regular wall suction. Okay, it's a wound vac suction, and it's on 24/7. Now, the purpose of the therapy is to pull granulation tissue, meaning if this large wound is expected to heal in 1 year or 2 years, the wound vac will cut it down to by 50 or sometimes 60%. So instead of healing in 12 months, this will heal in 6 months or less. Okay, look at the difference. See, look at the wound now. This was the start. Few months later, it's now this big. Okay, so it closes pretty fast. It saves you time, saves money. So what it does is it creates, because it's now negative pressure, it's wound vac, negative pressure. So is there any oxygen in here? It creates an anaerobic environment. So therefore, can aerobic organisms grow? No, not likely. So I mentioned earlier, the first surgical dressing is done by the surgical team, unless otherwise told or ordered. Use aseptic technique. Okay, we already talked about the post-op nausea vomiting. I'll skip that. Here's your discharge instructions for the patient. Now, unless otherwise stated, if there's no, like this one, if there's no dressing on the incision, that means the patient is free to shower. Bathing is not advised. I know it says here bathing, but is it really advisable to soak that incision with all your germs and snot and poop? No, shower is better, yeah? Okay. If there's a dressing, do not remove the dressing unless it's soiled or wet. Most surgical dressings now are long-term dressings, meaning they have silver in them, meaning they're literally called 7-day dressings, 14-day dressings. All right. So meaning, especially orthopedic surgeries, knees, hips, these orthopedic surgeons are very protective over these incisions because there's tens of thousands of dollars procedures. So they don't want any wound complications, right? So they use specialty dressings. These dressings stay on, very hard to remove. They stay on for 7 and 14 days. Okay, which is better than constantly removing them because there's always the human factor, right? Which will contaminate the dressing. So they trust the 7-day or 14-day dressings better than any nurse. Here, I already mentioned this earlier. So you mark the drainage, mark it with a pencil to see the progression of that dressing. There shouldn't be any pain, especially on the 3rd or 5th day. Same thing also for drainage. So if it continues to drain on the 3rd or 5th day, there's something wrong. Okay, the wound is not healing, so that's reportable. Okay, these are ways to reduce swelling of the incision. Once sutures or staples are removed, it's better to keep the incision open to air. All right, or if you want to cover it, maybe just with a dry gauze, but nothing occlusive. Okay, it heals better when it's open to air. Okay, so we discussed post-op nausea vomiting. Skip that. I'll go to the BTE. We'll talk about when we go to PE. Plus, you already did BTE last semester, yeah? I mean, MedSurg 1, DVTs. If not, we'll review it again when we go to pulmonary embolism. All right, let's go to the wound complications, which are dehiscence and evisceration, and this should be it. What's the difference between dehiscence and evisceration?
Right.
Dehiscence, and when the incision opens, evisceration is
When there's pressure.
bowels. Okay, bowels come out. Okay, pieces of bowels come out. Yeah, evisceration. Okay, so and these are the factors that will predispose to dehiscence and evisceration. Okay, obesity, malignant, cancer, diabetes, or people on steroids. Okay. So here's the illustration. So this is evisceration. This is no, sorry. This is evisceration. This is dehiscence. So in evisceration, that means there's also dehiscence, right? Otherwise, there would be no evisceration.
Like a prolapse.
Prolapse is coming out of a natural opening. Evisceration came out of an incision. That's the difference. All right, let's go to the intervention. So if disruption of a wound occurs, what do? Place the patient in a fowler position and tell them to stay still. Do you leave this patient? No, stay with the patient. If there are bowels coming out, what do? You don't push them back in? Okay, so you cover them with sterile dressings, moistened with sterile saline, and then surgery is notified at once. In this order, are we clear? What if there's no evisceration, just dehiscence? What do? Just the covering. Okay, so just cover the incision with a sterile dressing and then notify, call for help.
So just cover no ceiling, what, what's,
Same
Oh.
thing. Yeah.
so still place them in low Fowler.
So what is low Fowler? What position is that?
35. Looking at this one.
It's about 30 degrees. So it's in a reclined position, yeah? Why not sitting? Why not high Fowler?
It could further.
Okay, that will increase abdominal pressure and it will protrude, will push more organs out. That's it. It's been nice knowing you.
Next
Same.
week, we expect